like to talk to you today about treatment options for periprosthetic joint infections, specifically DAIR versus one-stage versus two-stage treatment. These are my disclosures, none of which are directly relevant to the conversations here, although I do consult for a company that makes irrigation solutions. What is the best way to treat these patients? You have a patient comes in with a wound that's opening or a wound you can see some fluid coming out of. How do you treat them best when it comes to infection? And unfortunately, we have all seen these patients. Here's an overview of the different treatment options you can do when it comes to periprosthetic joint infection. A patient presents with a PJI, and if the components are well fixed or it's an acute infection, irrigation debridement. If it's not well fixed, then potentially to take everything out, and you can do it in 1 stages or 2 stages. If it's a 1 stage, you go immediately to implantation of final components. If it's a 1.5 stage, meaning you can put an articulating spacer where there's a metal part here and a plastic part here, that's 1.5 exchange where you come back later at a longer point in time than a 2 stage. Or a true 2 stage where you take everything out, you have cement here, and then you come back at a later point in time and give you a new implant. If that fails, then you have the options of fusion and amputation if we're specifically talking about knees. When it comes to the 1 versus 2 stage versus DAIR, you can see that the morbidity and the efficacy of things like a DAIR procedure are lower. When you go to 1 stage, there's slightly higher morbidity, but slightly higher efficacy. 2 stage exchange has higher morbidity, especially since you're undergoing 2 different procedures, but you do have higher efficacy. What is it when it comes to the definition of timing for infection? There are multiple different classifications. One is the Tsukayama classification, where you see what types 1 through types 4. Type 1 is a positive intraoperative culture, and those are the type of patients you typically will treat with antibiotics afterwards. Type 2 is the earlier postoperative period, which is defined as an acute infection within 1 month of the index procedure, or an acute hematogenous source with less than 4 weeks or less than 1 month of symptoms. And then type 4 is the late chronic period after 1 month and is inoculation typically at the time of surgery. The McPherson classification shows different types of infection types, systemic host grade, and local extremity grade. The lower the number or the lower the letter, the healthier the patient is and the better they will do in DAIR. For those that are circled in blue, those type of infection types or low or an uncompromised host or uncompromised lower extremity will typically do better with a DAIR procedure. If it's other ones like a late chronic infection, also defined as 4 weeks, or a significantly compromised host or lower extremity, those patients might do better with a 2-stage exchange. The Zimmerli classification is another one that is used that goes for a longer time period. It goes for up to 3 months. They state that an early infection is within 3 months of presentation. And you can see how patients often present, which is pain, erythema, prolonged drainage, or fever, and typically these organisms are introduced to the surgical wound. These patients are likely to be able to be treated by an acute process or a DAIR procedure. Those who are delayed, presenting 3 months to 24 months after the onset of pain, typically will do better with a 2-stage exchange or a 1-stage exchange. Especially if a patient presents with implant loosening, you cannot perform a DAIR in those patients, and we'll go over those indications and contraindications. And late, if it's greater than 24 months, if they seed it and it's acute onset, then potentially they benefit from a DAIR, but otherwise 2-stage exchange is an option for patients. The International Consensus meeting met in 2018, and they came up with the definition for prosthetic joint infection. The major criteria is sinus tract and or 2 positive cultures. You can see here with the acute PJI, it's defined as less than 90 days, so very similar to the Zimmerli classification. You can see here that the numbers for C-reactive protein and synovial white blood cell count and polymorphonucleocytes are different than those who have chronic PJI, defined as greater than 90 days. How do we treat and look at acute PJI? This is often treated by something called DAIR. We've heard this as irrigation and debridement and polyethylene exchange, We've also heard it as debridement, antibiotic, irrigation, and retention of components, DAIR. Again, you preserve the prosthesis, you don't take it out. Ideally, you do it with a polyethylene exchange or a modular component exchange. What does that mean? Here's the technique factor you do. When you first start with the technique, and this is true not just for DAIR, but it's also true for 1-stage and 2-stage, you want adequate exposure using the existing scar. For a knee, it's typically in the anterior part of the knee. When it comes to a hip, it can be a different approach. For example, if the patient had an anterior approach, you could do this procedure through a posterior approach. Or if the patient had a posterior approach, you could do this through the anterior approach. So you could change the approach. Typically for a knee, you'll take an existing scar, and you want to have adequate exposure. So if a patient's really stiff, otherwise they've been infected for a long period of time or become thrombosed after surgery, the typical is a medial parapatellar approach. But sometimes you'll need to do a quad snip. You can do a VY turn down. There's a bunch of different options here because you need adequate exposure to get to your components. When it comes to debridement, I do this methodically. I make an incision, I make an arthrotomy, and then I take 2 Alice clamps and place them on the edge here and literally debride all that tissue on one side. And then you can see how here, if you invert the patella here, it's all cleaned and all debrided. You want to remove as much bioburden as possible. I call it like excavation. You're trying to remove as much of the bad stuff as possible. On the other side, you also put the Alice clamps and clean up as much as possible around the tissue itself. And you do this on both sides. So you typically have 2 people. One person does one side, the other person does the other side, and you clean all the necrotic tissue without debriding things like the collaterals or the tendons, because those are very important. But you need to have it as clean as possible, and it takes longer to do this part of the surgery than typically a primary knee replacement. Remove your modular component. Here's the modular component for your knee, and for your hip, you want to remove the polyethylene. Why do we do that? It allows you to get to the back part of the knee, so the posterior capsule, and behind the cup to allow you to clean as much as possible. You're trying to remove as much bioburden as possible. I typically use the 1/2-inch curved osteotome, and I put it into the plastic part itself for the knee, hit it down, and then wedge it outwards. And then for the same thing with the acetabular cup, I put it on the edge and hit it down. The other option you can do is use a screw, put it in, drill first, then put a screw, and then it pops it out. But you do have to use a screw for that. Physical disruption. It's important to disrupt the biofilm left on the implant itself. How can you do so? There's a variety of means to do so. One, you can take the scrub brushes and just scrub the surfaces. The only downside is it can scratch it a little bit. They have sterile toothbrushes. You can sterilize a toothbrush and clean the surface as well too. These are other equipment that tends to be more expensive. They might be used for plastic surgery or other modalities, but they act like a bone scalpel or a water pick, and they can clean the surface. This is pulse lavage. The only thing I caution about pulse lavage is that it can push bacteria into the tissue, which is not great. So a lot of people will use flow, where they just hook up the tubing and just let the water or the saline flow through and clean it out. So remember, all this equipment is to really prevent biofilms. So these are the biofilms that can form. It doesn't take long for a biofilm to form. A biofilm can form on a metal surface within 24 to 72 hours. And so you want to remove all that because you're keeping all the metal in a DAIR procedure. Irrigation, this is my own irrigation solution algorithm, but everyone has a different one. So I use 3 liters of normal saline. I combine povidone iodine with hydrogen peroxide. It gets very foamy, so you have to be able to suck it out appropriately. 3 liters of normal saline, sodium hypochlorite, which is also known as Dakin solution, 3 liters of normal saline, chlorhexidine, and 3 liters of normal saline. In some facilities, they have acetic acid available to them, and they'll use that as well too. So this is my regimen. After I do that whole regimen of cleaning, I take down the dirty stuff and I put all brand new clean stuff, meaning I put on new gloves and gowns and I use new equipment. I don't use the same old equipment, so I have 2 setups. I have 1 clean setup and 1 dirty setup, and the clean setup is all brand new, so I can use it afterwards because I don't want to use any dirty things in my newly clean bed. I put in the new polyethylene. I do trial again. You don't need a trial if you don't think that you need to have it. You think the size is the same, but I do like to trial and then put in the final components. I close it with monofilament suture. Doesn't have to be the suture, but this is an example of a monofilament suture. You just don't want braided suture because braided suture bacteria can come and attach to it. When it comes to a dressing, I like a dressing that is completely sealed so the wound can heal, ideally for 7 days before you remove the bandage. If you don't have options of this, any sort of dressing that's going to keep the patient from touching the wound, that's a good thing. What's the advantages of successful DAIR? The success is from 0 to 90%, meaning it can be 100% failure or it can be 90% success. And when you do it, the benefit is that less is more, right? You don't need to remove your implants, so there's no bone loss, there's less blood loss, and ideally less pain. So it's good to have that. It's technically easier. You can see here just taking the plastic part out there is much easier to do than to take everything out. Again, it's less time consuming, so the patient's under anesthesia for a shorter period of time, which is good, especially for our sick patients. And there's less morbidity and mortality to it. You can see here, it's better recovery, less of a physiological insult, and better function after surgery, which is a benefit for a lot of patients. The idea here is that if you have prolonged symptoms, and the problem is the duration of time differs depending on the classification you're looking for. 4 weeks is a very safe timeline if you want to go up to 6 weeks. If you have greater than that, you're going to want to think about, you don't want to do a DAIR. If you have a sinus tract, meaning if you have fluid coming out, you probably don't want to do a DAIR. If you're unable to close the wound, a DAIR would not be good because you won't get healing and you'll get reinfected again. If your implants are unstable or they're loose, you don't want to do a DAIR. If they're immunosuppressed or have an ASA classification, which is the American Anesthesiologist Association classification of 3 or 4, meaning they're pretty sick and they're likely to become infected again, then a DAIR may not be the best option for them. If they have a really difficult to treat pathogen, things like vancomycin-resistant enterococcus or methicillin-resistant Staph aureus, then maybe doing a DAIR is not the best idea. If they have a DAIR history in the index joint, meaning they already tried a DAIR and they failed, may not be a good idea to do it again. And finally, if they had a previous arthroscopic DAIR, if they had any of these criteria, you should probably stop and consider not doing a DAIR in these patients because they may not do well. So what can you do in these patients? Your option becomes 2-stage exchange arthroplasty. The benefits of 2-stage exchange arthroplasty are they have high infection control rates. They do have successful ratification of up to 91% of atypical and resistant organisms. So really good for resistant organisms. Longer follow-up and survivorship rates in 2-stage versus 1-stage. And again, historically better infection control than 1-stage and DAIR. It is still the gold standard globally in Asia, Pacific, North America. Europe is the main place that does 1-stage exchange arthroplasty. When should it be used? Ideally in patients who are septic, meaning they're very sick medically throughout their whole body. So you need to get rid of the source of their infection. Now the trade-off is the surgery itself typically takes longer, so these patients may not be able to endure it. If they can't, then you might have to perform a DAIR, but ideally you do a 2-stage exchange. If they are lacking soft tissue coverage, again, 2-stage exchange to allow for some soft tissue coverage. If they're infected with a resistant organism, and if they've previously failed a DAIR. What are important things you need to know? The approach is the same. You want to get good exposure. You want to debride and remove all that tissue like we covered with DAIR, but you need to do something different this time. You need to take out the old equipment. I typically like to use a microsagittal saw. It's a very, very tiny saw with a very thin blade. I want to preserve as much bone as possible. So I put this blade between the implant and the cement interface. So you don't want to put between the cement and the bone, you want the implant and the cement, and you cut right inside there. After I cut with that saw, if the saw is not available, I use an osteotome. I like the 1/4-inch osteotomes because they're very small and get into small spaces, especially for small patients, that's good, but it's good for all patients. So this is an example of a 1/4-inch osteotome, both straight and curved. I use the curved one around the back of the knee, and that really does help. I use these sort of devices. They're called Moreland osteotomes in our facility. They help break up the cement mantle. So if they have previous cement, you need to get rid of all the cement in the cases of infection. So I use these things that help put it down the canal, and you can break up the cement and then you can grab out the cement. I also like to use a burr. A burr is really nice because it cleans the surface and removes anything that we don't want to keep there, especially cement. What do I fill it with afterwards? There's options that we have. There's cement spacers that provide infection control. They can deliver local antibiotics, and they protect and maintain soft tissues. Ideally, they can maximize post-operative function, but it really depends on which spacer you use. There's articulating spacers where they're basically curved and they look like a knee replacement, or non-articulating or static spacers which stay in place. They do have similar rates of reinfection, but articulating spacers have better range of motion. You can see here an example of an articulating spacer. You can see this is a part up here and a part down here, and it curves. It typically maintains the joint space, so when you go back in, it is easier to put in new implants. Same functional scores for the patients, same infection eradication. It does cause less bone loss because there's no removal of things there, increased range of motion, but it is more expensive. The implants are more expensive for articulating spacer than a non-articulating spacer, and they can dislocate or fracture. Non-articulating, you want to maintain your joint space, similar functional scores in infection eradication. Now, if you have bone loss or if you have extensor mechanism problems, meaning you have no patellar or quadriceps tendon function, then putting a static spacer is ideal because it allows all the soft tissue to heal and allows a patient to elevate their leg. It is easier to make and it is more cost effective. These are different types of articulating spacers. There's cement on cement. Basically, you create a mold and you put in here. These molds are very expensive. Now you can create your own, but it'll grind a little bit. You can see here, this looks like a femoral implant, this looks like a tibia implant, and then there's metal bars up and down here that have local antibiotic delivery. I use a K-wire, a really big Steinman pin, basically, and coat it with cement, and then put it up and down the cement areas. You can do something called a metal on polyethylene one, so you can see here, this is a metal piece here, this is cement here and a stem, and then a polyethylene, and they've built it up with some cement with another stem in here. So it's a well-balanced knee, and the idea is that it can function like a regular knee, but there's antibiotic cement present, which does weaken the cement a little bit. Non-articulating spacers are great against with patients with uncontrolled infection, bone loss, extensor mechanism difficulties, or deficient ones, and compromised soft tissue. Here's another example of a static spacer where you just put a wad of cement in. This can move, which I don't love. Another potentially cost-effective way of doing so is to take a pin and put it in there. You can also put a X-Fix bar. So if you have an X-Fix bar that's already been used, you can sterilize it and then use that for your static spacer. You put it up the femur and down the tibia so it spans the knee. The advantage is that with joint immobilization, it can reduce inflammation with severe infection, but there are reduced limb and joint function. Remember, reduced range of motion because of that. And there is potential for bone loss, and it is more difficult to do from an operative standpoint to convert from this type of spacer to from the other type of spacer. Well, how much antibiotics do you put in your cement spacers? The idea is that they can go up to 3 months of local delivery, which is nice. It's a high concentration elution, especially initially, and it's thermally stable. Typically, people use vancomycin, tobramycin, and gentamicin. You want a combination of medications that are good for gram-positive, which is vancomycin, and gram-negative, which is tobramycin or gentamicin. Tobramycin and gentamicin are much more expensive than vancomycin, and they all go through the kidney, so you need to be very careful of acute kidney injury. People will vote up to 3 to 4 grams of vancomycin and 1.2 to 2.4 grams of tobramycin in each bag of cement. I personally use 2 grams of vancomycin and 2.4 grams of tobramycin in each bag of cement, depending on the organism. What do I mean by depending on the organism? It depends on the organism. It depends what type of antibiotic you'll use. Here's a list of antibiotics that can be utilized, and it gives you the range of grams per bag of cement. These are all heat stable and all good to be used within cement itself. Daptomycin is an available drug, but it's typically not used for concern for myelitis. myositis. And then cefuroxime and clindamycin are not in sterile powder form in the US, but may be available in other areas in powder form and not expensive. These are medications that fit mostly gram-negative bacteria. And you can see a whole list here that are, again, all heat stable with different amounts of antibiotics there. We also have antifungals as options. If you have a fungal infection, these are harder to come by, but these are the dosages that can be used per bag of cement. What are the limitations of two-stage arthroplasty? There are increased morbidity and mortality, as we showed earlier in the slides, and there are multiple operations, not just one, but 2 operations. There is impaired mobility, and there can be soft tissue contractures between the 2 operations, so range of motion and function can get a little bit worse with time. Longer hospitalizations, if you add up the 2 different hospitalizations for surgery, it is expensive. And in between stages, especially if they have a static spacer, it's really hard for someone to take care of them. So there is a big burden on someone else besides just the patient. What's the true success rate of two-stage exchange arthroplasty, meaning no infection, no mechanical failure, no operation? We all think it's very high, but it's actually only been 65%. It's not as high as we think it is when it comes to truly eradicating infection. One-stage exchange arthroplasty is another option. You do a single procedure where you remove all the infected parts, debride the infected tissue, and then reimplant. It's all the things that we discussed before, but instead of closing the patient and coming back another day, you close the wound, you change scrubs, you have new instruments, you re-prep and re-drape, and you start like from scratch, but you do it during the same day. What are the indications? You can see all the indications here. All right, these are ones where it's non-compromised host, there's no sepsis, minimal bone loss or soft tissue defect. The microbiology is ideally not a resistant organism, so you don't have to treat them for longer antibiotics. Isolation of the pathogenic organ ahead of time is ideal, so you know what you're treating, and you also know the sensitivities, so you know what antibiotics to give. All these below are relative contraindications to one stage. The surgeries can still be done one stage, but these are relative contraindications. How do you perform a one-stage exchange? You remove all the components, including cement, just like you do in a two-stage. You do an extensive debridement, exactly like we've talked about before. Irrigation, you can do the exact same irrigation that you do for your DAIR. I do that for my two-stage exchanges, for my one-stage exchanges. And then what I do is I take a betadine sponge and I soak it and I put it in the wound and then I stitch it up. And then I put a piece of iodoform dressing on top of it. And then I leave the room, we clean the room. If you have an opportunity to have a new room, that's great. Typically we don't have a new room, so we clean the room as much as possible. All our staff changes brand new scrubs, we scrub it again, and we open new instruments. Similar to the DAIR, you want to have new instruments available when you're coming back in with the clean stuff. You re-prep the surgical site, you remove the dressing, you make sure that that sponge is counted, and you put in new revision implants with antibiotic impregnated cement, and you close with monofilament and use a dressing again as well. What are the benefits? There are comparable rates of infection control. There's low reinfection rates and high success rates, but these are typically done by people who do a lot of these. There is a shorter hospital stay compared to a two-stage. It is cheaper because you don't have that interim spacer in between that you have to pay for. They have quite good functional outcomes because there is no time frame when they're down, and less antibiotics because it's one-time operation. You can see here that the survival rates are pretty good. This is from the EndoClinic 10-year total hip results. What are the limitations? There is a lack of large multi-site studies. There's one that's being conducted now, and we haven't had the results yet, but preliminary results demonstrate the one stage is quite good. There is increased risk of reinfection because there is no time frame when antibiotics are eluting cement for a long time before you put in the new implants. It might remove too much soft tissue, so the EndoClinic method is to remove the medial and lateral collaterals, so they put a hinge in every patient, and there's limited local antibiotic delivery at the time of surgery. So the problem is in a one-stage exchange, you're typically using off-the-shelf antibiotic cement because you want it to be stronger. If you're doing a two-stage, you're doing antibiotic cement that's a little bit weaker, but that's okay because it delivers more antibiotics. What do we give after surgery? Intravenous antibiotics. This is one thing you can do. These are different examples of very commonly used antibiotics intravenously. Ideally 2 to 6 weeks after surgery. The Europeans do it for 2 weeks. We typically do it for 6 weeks here in the United States because that's the definition for an osteomyelitis treatment. And then some infectious disease doctors want patients to be on oral antibiotics, typically 3 months for hips and 6 months for knees. Here are examples of oral antibiotics. It'll depend on the organism that you have present as to what medication the patient would get. So in conclusion, DAIR 1-stage and 2-stage exchange arthroplasty provide good treatment of periprosthetic joint infection, but you have to make sure that you choose the right surgery for the right patient. Meaning if a patient's been chronically infected for a long time, a DAIR probably won't work as well for them. If their implants are loose, again, a DAIR won't work well for them. Methods of performing all of them are crucial. No matter what approach you do, whenever surgery you do, you want to have good exposure and a very thorough debridement. You want to treat it like tumor surgery and take everything out that's infected as much as possible. You want to choose an antibiotic cement that's specific to the infectious agent, and it's important for infection control. And there are ongoing prospective randomized controlled trials looking at these different treatment options, and hopefully they help direct us in the future. Thank you very much for your time.